Hello and welcome to Module 5, where we will be focusing on cardiovascular disease. As you may know, atherosclerosis, which is the hardening and narrowing of arteries, gets a lot of bad press, but with good reason. This progressive process silently and slowly blocks arteries, putting blood flow at risk. It is the usual cause of heart attacks, strokes, and peripheral arterial disease, what together are called cardiovascular disease. Atherosclerosis begins with damage to the endothelium caused by high blood pressure, smoking, or high cholesterol. When LDL cholesterol crosses the damaged endothelium, the cholesterol enters the wall of the artery and becomes oxidized. This activates an immune and inflammatory response, which then leads to the formation of plaque. The atherosclerotic plaque is essentially a jumble of cholesterol, cells, and debris that creates a lesion on the arterial wall. As atherosclerosis progresses, that lesion gets bigger, and when it gets big enough, it can create a blockage. That process goes on throughout your entire body. As a result, not only is your heart at risk, but you are also at risk for stroke and peripheral arterial disease. The latest American Heart Association statistics report that approximately 8 million patients in the United States are affected with peripheral arterial disease, or PAD. This includes 12 to 20% of individuals older than the age of 60, with an even larger number remaining undiagnosed. Thus, the total PAD burden is estimated to be as high as 12 to 14 million in the US alone. The classic symptom of PAD is pain in the legs, with exertion such as walking, which is then relieved by rest. However, up to 40% of individuals with PAD have no leg pain. Symptoms of pain, such as aching or cramping with walking, known as claudication, can also occur in the buttocks, hip, thigh, or calf. Other physical signs in the leg that may indicate PAD include muscle atrophy, hair loss, smooth, shiny skin, skin that is cool to the touch, especially if accompanied by pain while walking, decreased or absent pulses in the feet, non-healing ulcers or sores on the legs or feet, as well as cold or numb toes. Endothelial dysfunction is a response to cardiovascular risk factors and precedes the development of atherosclerosis. The endothelium exerts a number of vasoprotective effects, such as vasodilation, suppression of smooth muscle cell growth, and inhibition of inflammatory responses. Many of these effects are largely mediated by nitric oxide, the most potent endogenous vasodilator. Nitric oxide, or NO, is produced from the amino acid L-arginine by the enzymatic action of nitric oxide synthase, or eNOS. Vascular actions of nitric oxide include the following: direct vasodilation, as well as indirect vasodilation by inhibiting vasoconstrictor influences, and it also has an antithrombotic, anti-inflammatory, and an anti-proliferative effect. The most important stimulus for the continuous production of nitric oxide is viscous drag, which creates something called shear stress. This is related to blood flow across the endothelium. Shear stress increases the expression of eNOS, which in turn causes vasodilation. Conditions such as hyperglycemia and insulin resistance have an inhibitory effect on vasodilation via eNOS suppression. Similarly, regulatory kinases involved in these pathways are also affected in disturbed inflammatory and insulin signaling. Previously viewed as inert oxidative end products, recent studies surprisingly show that nitrate and nitrite can also be metabolized in the body to form nitric oxide. Inorganic nitrate and nitrite derived from various dietary sources are acted on by bacteria in the oral cavity to produce nitrites. This represents an important alternative source of nitric oxide. A picture is now emerging suggesting important biological functions of the nitrate-nitrite-nitric oxide pathway with profound implications in relation to the diet and cardiovascular health. An increasing number of studies suggest a therapeutic potential for nitrate and nitrite in diseases such as myocardial infarction, stroke, hypertension, renal failure, and even gastric ulcers. Mammalian tissues produce nitric oxide to modify protein-specific sites, thereby regulating vital cell functions. The majority of nitric oxide produced is widely assumed to be neutralized into supposedly inert oxidation end products such as nitrites. This study, however, showed that nitrite, commonly found in dietary sources, is remarkably efficient at modifying the same protein sites. It was found that nitrite affects cyclic GMP production, cytochrome P450 activities, and heat shock proteins in a variety of tissues. These cellular activities of nitrite, combined with its stability and abundance in the body, suggest that it has an important signaling role in mammalian biology. Thus, nitrite homeostasis may be of great importance to nitric oxide biology. This study, in 2009, looked at dietary nitrites and their role in vascular inflammation and endothelial dysfunction, and found that mice fed a cholesterol-enriched diet exhibited significantly elevated leukocyte adhesion and immigration through the endothelium, as well as impaired endothelium-dependent relaxation in the arterioles. Administration of nitrite in their drinking water inhibited the leukocyte adhesion, as well as the immigration, and prevented the arteriolar dysfunction. This was associated with decreased levels of C-reactive protein as well. These data reveal novel anti-inflammatory properties of nitrite and implicate the use of it as a new natural therapy for microvascular inflammation and endothelial dysfunction associated with hypercholesterolemia. Approximately 80% of dietary nitrates are derived from vegetable consumption. Sources of nitrites include vegetables, fruits, and processed meats. Nitrites are produced endogenously through the oxidation of nitric oxide and through a reduction of nitrate by commensal bacteria in the mouth and gastrointestinal tract. As such, the dietary provision of nitrates and nitrites from vegetables and fruit may contribute to the blood pressure lowering effects of the commonly used DASH diet. Beetroot provides an excellent source of nitrate, and as we've seen, dietary nitrate provides an important substrate source for the nitric oxide production pathway. However, sufficient levels of nitrate from dietary sources may not be likely, indicating benefit of supplementation in some individuals. This study supplemented a single 500 ml dose of beetroot juice, which was found to lower blood pressure at 3 hours post-dose in healthy subjects, and also protected against ischemia-induced endothelial dysfunction, which was measured by flow-mediated dilation. Dietary nitrate supplementation significantly lowered blood pressure in healthy young volunteers. The effective dose is equivalent to 150 to 250 grams of leafy greens, which is not likely to be consumed at one meal. For raw spinach, this equates to approximately 8 to 12 cups. The amino acid L-arginine is another novel nutritional strategy to potentially stave progression of vascular dysfunction with aging and cardiovascular disease, as it is a substrate for the synthesis of nitric oxide. Results from the collective of available literature indicate that supplementation with L-arginine in patients with non-obstructive coronary artery disease significantly improved coronary blood flow in response to acetylcholine compared with placebo. Improved forearm blood flow in patients with moderate to severe heart failure, and also significantly improved flow-mediated dilation of the brachial artery compared with placebo in a healthy elderly population. One important aspect to note, however, is that arginine should not be recommended following acute myocardial infarction. This randomized clinical trial published in JAMA 2006 found that L-arginine, when added to standard post-infarction therapies, did not improve vascular stiffness measurements or ejection fraction and may actually be associated with higher post-infarction mortality. Magnesium is another important nutrient for cardiovascular health. A study published in the American Family Physician 2009 looked at the therapeutic uses of magnesium. It found that magnesium supplementation has been associated with inverse risk of coronary heart disease in men, an inverse risk of metabolic syndrome, improvements in glucose and insulin metabolism, as well as improvements in cardiac arrhythmias. Magnesium also plays a positive role in supporting endothelial function. 1 month of magnesium supplementation at 4.5 grams per day significantly improved post-ischemic endothelial-dependent flow-mediated dilation in elderly diabetic and hypertensive patients. Stable coronary artery disease patients supplemented with magnesium for 6 months in a randomized, double-blind, placebo-controlled study resulted in a significant improvement in flow-mediated dilation, better exercise tolerance, and less ischemic segment changes. Now let's focus on dyslipidemia, another major contributor to atherosclerosis and heart disease. Traditionally, the goal of therapy is to lower total cholesterol, as well as LDL, triglycerides, and lipoprotein A, while raising HDL cholesterol. As it turns out, there are many natural ways of doing this, and we don't have to be solely dependent on prescription medications. Lipoprotein A, or LPA, has recently received a lot of attention. It is an LDL molecule linked to apolipoprotein A. This is the really bad cholesterol. So if LDL is bad, then LPA is evil, the really nasty stuff. As compared to elevated LDL levels, elevated LPA denotes even greater risk. As it says here, a given quantity of LPA in the blood seems to confer as much added risk as does 10 times the quantity of LDL. Possible mechanisms at work include that the LPA may slow down the breakdown of clots, promoting thrombosis. It may signal for inappropriate growth of the cell lining, causing a closing or occlusion for blood flow, and contributes to plaque buildup in the arteries and formation of foam cells, which we know leads to atherosclerosis. Now, niacin is a very interesting medication. As most people know, niacin is a B vitamin, but to change cholesterol values requires much larger amounts than the body requires as a vitamin. So you need to think of it as a drug, not a vitamin. Niacin lowers cholesterol as well as LDL, but it is also the most effective agent available to raise HDL cholesterol, the good cholesterol, and it also has the ability to reduce triglycerides. Here we can see a meta-analysis of 7 trials which used niacin and found that it was associated with a significant reduction in cardiovascular events. The typical reductions one can expect to see with niacin therapy are increases in HDL of between 10 and 30%, reductions in triglycerides of between 20 to 50%, and LDL and LPA were reduced by 10 to 30%. Niacin, or vitamin B3, is a generic term that actually refers to both nicotinic acid or nicotinamide, sometimes called niacinamide. Tryptophan, an amino acid, can also be converted in the body into niacin, as long as there's adequate levels of B6, B2, and iron. It takes about 60 milligrams of tryptophan to produce 1 milligram of niacin. So up to 50% of our daily niacin requirements can be obtained from tryptophan conversion. Milk and eggs have small amounts of niacin, but they're actually high in tryptophan and thus contribute significant niacin equivalents to the diet. Good sources of niacin include yeast, meat, poultry, red fish such as tuna and salmon, cereals, legumes and seeds, as well as green leafy veg, coffee and tea, which contain some niacin. Niacin is required for the production of two coenzymes, NAD and NADP. Up to 200 different enzymes in the body require either of these coenzymes. NAD is most often used in energy-producing reactions involving the breakdown of carbohydrates, fats, proteins, and alcohol. NADP functions more in the synthesis of macromolecules like fatty acids and cholesterol. In 1955, it was discovered that nicotinic acid had an influence on cholesterol in man. In the years since then, it has been established that the positive role is related to only nicotinic acid and not niacinamide. Parallel tests with nicotinamide showed no definite influence on serum cholesterol levels in 20 healthy medical students. In a study comparing nicotinic acid and nicotinamide, where nicotinamide was substituted for 12 weeks, the average serum cholesterol levels rose to a value approximating the pre-treatment level. So niacin, in the form of nicotinic acid, has been shown to favorably affect total cholesterol, LDL, triglycerides, lipoprotein A, and HDL levels. This study from Elsevier in 2009 states that triglyceride levels are reduced by 20 to 50%, LDL by 10 to 25%, specifically targeting the small dense LDL, and HDL increased by 10 to 30%, making niacin the most effective drug currently available for raising HDL. The dose that is typically used in this particular study was 2 grams per day. It was able to lower LDL, triglycerides, and LPA by 15%. Important to note is that niacin is also the only agent that effectively lowers plasma lipoprotein A. So as you are aware, the current practice for managing blood lipids is utilizing a long list of medications in combination, usually a statin and a cholesterol blocker, but we know this isn't without side effects. It was seen that patients with familial hypercholesterolemia using a statin and a cholesterol blocker together did not improve the intima media thickness as compared to the simvastatin alone, despite decreases in LDL levels. So what this means is that although one marker, the LDL, was improved, the combination of the two medications did not result in improvements in the intima media thickness, which is a marker of atherosclerosis. This comparative effectiveness trial from the New England Journal of Medicine in 2009 shows that the use of extended-release niacin causes a significant regression of carotid intima media thickness when combined with a statin, and that niacin is superior to a cholesterol-blocking medication. These results from the study show that although the cholesterol blocker was better at reducing LDL and total cholesterol when compared to the niacin, this is the red line, the niacin was significantly better at improving the HDL. It actually fell in the cholesterol blocker group, and triglycerides were also more favorably affected by the niacin. Also, a test used to measure and diagnose the extent of carotid atherosclerotic vascular disease, the intima media thickness, you can see that the blue line, the cholesterol blocker, barely had any effect, while the niacin showed great improvements. It must be noted that there can be some side effects experienced in certain individuals when it comes to niacin therapy. Typically, what you'll see is flushing and itching and possibly some gastrointestinal symptoms. This can be mitigated by starting on a very low dose and gradually increasing it, as tolerance usually improves over time. There is, however, another form of niacin that does not produce these side effects, inositol hexanicotinate, or IHN. IHN is more slowly metabolized by the body, and does not produce the side effects that niacin does. Yet, it's just as effective at lowering cholesterol. It is also useful in other conditions, including intermittent claudication, which is a symptom of peripheral arterial disease. So IHN is the preferred form of niacin to use for these patients because you get the benefits but not the side effects. Here is a diagram of IHN, which shows its chemical structure. As you can see, it consists of one molecule of inositol surrounded by 6 molecules of niacin. As mentioned before, it's metabolized slowly in the intestines and therefore released more gradually into circulation, producing the benefits without the side effects. And human studies have demonstrated its bioavailability and improved tolerance. The mechanism of IHN is fundamentally the same as niacin. It decreases cholesterol and VLDL synthesis in the liver, so it blocks cholesterol synthesis, thereby reducing serum total cholesterol, as well as LDA and lipoprotein A. At the same time, it increases HDL by blocking its breakdown in the system. It also improves peripheral glucose utilization, which also affects blood lipids. You also get the added lipotropic effect of inositol. Inositol helps the liver to utilize and excrete lipids properly. Typically, the dosage of IHN is 1 to 3 grams per day. As it says here, IHN treatment produced significant decreases in total lipids, phospholipids, total cholesterol, triglycerides, lipoproteins, and body weight. These data revealed that the hypocholesterolemic effects of IHN was more pronounced than nicotinic acid. So it is similar to regular niacin, but more effective, and as we said, better as far as side effects are concerned. Another nutrient that is excellent for lowering blood lipids is gugulipid, a funny name but an interesting substance from India. Although used in India for a much longer time, it's been on the market in the US since 1988 and is quite a potent lipid-lowering agent. Its mechanisms of actions are believed to be that it enhances excretion of cholesterol through bile, so it improves the conversion of cholesterol into bile, prevents the reabsorption of that bile, and helps with the excretion of bile in the stool. It also inhibits cholesterol synthesis and increases the number of hepatic binding sites for LDL cholesterol, thus drawing more cholesterol out of circulation. Studies reported in the Journal of the Physicians of India, report significant lipid-lowering effects. They found a 23% reduction in cholesterol and a 22% reduction in triglycerides on 1,500 milligrams per day of the gugulipids. In another crossover double-blind study of 125 patients on Google and 108 patients on clofibrate, which is a lipid-lowering drug, there were very similar results in lipid reduction. In addition, the Google raised HDL cholesterol in 60% of the responders, whereas the clofibrate had no effect on HDL. So increases in HDL is an advantage of Google over this medication. So just to summarize, gugulipids lower total cholesterol, LDL, and triglycerides and increase HDL cholesterol. When you combine it with inositol hexanicotinate or IHN, you have a synergistic effect on blood lipids. So the two nutrients together are an excellent regime for lipid lowering and increased HDL. Now some of you may be familiar with another natural alternative for cholesterol reduction, red yeast rice. It has been used for centuries in China as both food and medicine. It is made by fermenting a type of yeast called Monascus purpureus over red rice. Red yeast rice naturally contains several ingredients that may help control cholesterol levels. These include a number of monocolins or actives, most importantly monocolin K, which has the same makeup as the drug lovastatin. In addition, it also contains sterols, isoflavones, and monounsaturated fatty acids. Results from the collective of available literature indicate that consumption of 1,200 milligrams per day red yeast rice may result in significant reduction in cholesterol, with observed average reductions in LDL of 21 to 34%. This study from the American Journal of Clinical Nutrition in 1999 showed that red yeast rice significantly reduces total cholesterol, LDL cholesterol, and total triglyceride concentrations compared with placebo. Plant sterols and stanols are substances that occur naturally in small amounts in many grains, vegetables, fruits, legumes, nuts, and seeds. They have been shown to have powerful cholesterol-lowering properties. On a molecular level, sterols and stanols actually look a lot like cholesterol. So when they travel through your digestive system, they get in the way and block up the real cholesterol, and they prevent it from being absorbed into the bloodstream. So instead of clogging up your arteries, the cholesterol just goes out with the waste. Several studies have observed a hypocholesterolemic effect of plant sterols in hypercholesterolemic patients on a balanced diet. The aim of the study was to examine the effect of phytosterol supplementation on risk factors of coronary artery disease in metabolic syndrome patients that were following a westernized type diet. In a randomized placebo-controlled design, 108 patients with metabolic syndrome were assigned to consume either 2 plant sterol-enriched yogurt drinks, which provided 4 grams of phytosterols per day, or a yogurt beverage without the phytosterols. The duration of the study was 2 months, and the patients in both groups followed their habitual westernized type diet and recorded it in food diaries. Blood samples were drawn at baseline and after 2 months of intervention. At the 2-month point, after supplementation with the phytosterols, they found a significant reduction in total cholesterol, LDL cholesterol, small and dense, as well as ApoB and triglyceride concentrations. They were significantly improved compared to the control group. In addition, phytosterol supplementation lowered serum cholesterol by 15.9%, LDL cholesterol by 20.3%, and triglyceride levels by 19.1%, even though the patients did not alter their diets. This study from the American Journal of Clinical Nutrition shows that at a dose of 1.8 grams per day, LDL cholesterol concentrations were 11.3% lower in the plant sterol group, and cholesterol absorption efficiency was 56% lower in the plant sterol group. For heart health, vitamin K2 shows numerous advantages over vitamin K1, including better absorption and increased protection against heart disease. Vitamin K2 appears to be the form of vitamin K that contributes to controlling all of the abnormal deposition of calcium in the body, such as in the lining of the arteries or the heart valves. In 2004, in the Rotterdam Heart Study, a Dutch trial that tracked 4,800 participants for 7 years, they found that higher intakes of vitamin K2 corresponded to less calcium deposition in the aorta, whereas participants who ingested less K2 were more likely to show moderate or severe calcification. The lowest risk of heart attack and aortic calcification was seen in participants who included more than 32.7 micrograms a day of vitamin K2 in their diets. The MK4 and MK7 forms of vitamin K2 have demonstrated important health benefits in numerous studies. While the MK4 form has been shown to support cardiovascular and bone health, the MK7 form is exceptionally long-acting and reaches higher levels in the blood. CoQ10 has also been shown to benefit patients with cardiovascular diseases, including hypertension, congestive heart failure, cardiomyopathy, angina pectoris, and heart attack recovery. This study from Diabetes Care in 2009 found that CoQ10 supplementation improved endothelial dysfunction in statin-treated type 2 diabetic patients by altering local vascular oxidative stress. Now, there are numerous reasons why CoQ10 levels may not be adequate in any individual. This may be due to genetics or aging, and of course certain drugs or disease states which deplete levels. Here you can see how there is a natural age-related decline in CoQ10 levels which becomes significant around the age of 40, where you can see that in the heart tissue concentrations have been reduced to 68%, with the lungs being reduced to 72%. This decline continues to become more pronounced as we age, and we can see that the kidneys also become quite depleted. Most of you will be aware that HMG co-reductase inhibitors, or statins, are associated with the depletion of CoQ10. This study states that statin-induced CoQ10 depletion is well documented in animal and human studies, with detrimental cardiac consequences in both animal and human models. This drug-induced nutrient deficiency is dose-related and more notable in settings of pre-existing CoQ10 deficiency, such as in the elderly and in heart failure. Statin-induced CoQ10 deficiency is completely preventable with supplemental CoQ10, with no adverse impact on the cholesterol-lowering or anti-inflammatory properties of the statin drugs. Now, when it comes to replenishing CoQ10 levels, the common dosage is 60 milligrams twice a day. However, to treat statin-induced myopathy, it has been noted that doses in excess of 300 milligrams may actually be required. This chart shows the dosage ranges for CoQ10 supplementation that are recommended by the doctors working at the Functional Medicine Research Center, the research arm of Metagenics. And as you can see, the minimum that they use is 100 milligrams per day for healthy patients over 40, while the levels for the remainder of the categories are from 200 but up to 600 milligrams per day. Join me in part 2 to have a look at some of our Metagenic solutions that use some of the approaches mentioned in part 1. Thank you.